Okay.
Whoa, hello.
There we go. That patient
Hey.
comes in, I'm pretty confident
Yeah.
on that one.
And
Yeah.
I'm like, wow, you're excited. What? Nothing?
Most common orbital disease in North America and Europe would be the thyroid eye disease, frequently associated with Graves' disease. So often occurring in patients with hyperthyroidism, and hence that's why you end up treating so that question was, how confident are you in treating? Well, you're not going to treat their hyperthyroidism.
Right.
That's going to be into an internal medicine practitioner.
To the one point though, is that you, my friends, are the primary care doctors when it comes to the eyes. And most often, these patients may or may not realize they have hyperthyroidism. It may be just very minor changes, but they might notice, as Doug said earlier, they feel their eyes. They don't want to feel their eyes.
And it mimics, their feelings that they have is dry eye disease.
Yeah.
They feel the grittiness, they feel...
Do you think that it's thyroid dry eye disease? So it's TD head? Because it is Sunday. So
Yes.
is it TD head? Dun, 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 dun. Yes. Yes. Maybe.
I always get something profound out of you.
Yeah. There it is, people.
So the symptoms, the bulging, and then the inflammation, dryness, bloodshot pain, impaired vision. I think then a lot of patients will think, okay, well, I have dry eye. And so you may be treating some of these patients as well. And we certainly can do exophthalmometry on those patients if we feel we're starting to get protrusion.
Do you remember, so when I was in school, we had all these like acronyms, and one of them was like PERLA. PERLA is my favorite because I had a student once who basically said the patient was PERLA, and I go, really? PERLA? And what does PERLA mean? And they just stared at me. And you've got a student the way you want them when they're just staring at you, right? And he's like sweating, a little sweat. I go, can you just define PERLA for me? Because I think what I knew that he obviously didn't, this person basically had a prosthetic eye. A PERLA. Okay, bye-bye. But we had no specs. Do you remember no specs? And it was a way of evaluating patients with thyroid disease. So N was no signs or symptoms. O was only signs. S was symptoms. The P was something. See how well I did? E was EOMs. C was corneal involvement. And S was sight threatening. Boom, nailed it. Forgot what one of them was, but if you know it, put it in the things there. But that's just a way of kind of like seeing the evolution of this.
Back in March, these questions were asked, and 58% of the respondents thought that, somewhere between 1 and 5%.
Isn't that funny how that mirrored the 53,000 patients or doctors that we have on our webinar right now? Yeah.
So what does Gloria say?
Gloria, she says this low prevalence squares pretty well with the data, which reports a similarly low prevalence.
Yep.
We nailed it, friends. We nailed it.
What is the incidence?
3 out of 100,000 people,
Yeah.
Doug.
Okay.
Which is, and most people are assigned male at birth, but 16 out of 100,000 people assigned female at birth. Okay? And this is a hard slide for you to read, Doug, so I'll read it for you. So basically, 3 out of 100 people that are assigned male.
Put your red hat away, is that what you're talking about?
Oh, Dr. Kate, you gotta love her. You gotta love her. Okay?
Yeah, that was just a little jab.
But what are 2 peaks of incidence? Oh, that's really interesting. And I don't think most people realize this, that you start to see TED basically hit around 40 to 50, and then it peaks up again about 60 to 70. So you get that double hump. And that is a lovely picture. That was a lovely picture. Can I also let everybody know that we are reaching the halfway mark. So if you need a bio break, don't stand up, just do it. Because that's what Doug and I are doing.
As we speak.
I am bio breaking right now, Doug.
Okay, again from March, what signs and symptoms do you use to diagnose thyroid eye disease? And that's, proptosis, dry eye, double vision, and we see this scattering of that the practitioners used and kind of looking at, and it really is, there's a whole bunch of things going on. Optic neuropathy, there's a lot. The optic neuropathy, of course, would be down the road as that proptosis, and it's choking off that orbital fat, choking off that nerve.
And by the way, P stands for proptosis. Nailed it.
Now that
Now that Gloria told me that. What does Gloria say about their trends?
Well, Gloria says,
boom, proptosis, most commonly cited symptom. though there wasn't any other clear consensus, and all but optic neuropathy was selected by over 60% of recipients, which is interesting.
Yeah.
So again, I think that we look towards that proptosis. I mean, when's the last time you pulled out your Herzl exophthalmometer, right?
It's been a while.
I wouldn't even, I would fumble through that thing. I wonder if any first-year optometry students, I'm gonna have to ask my first-year optometry son if he knows how to use it, and he can teach me. Here you go. Yeah.
Well, and the pathology of thyroid eye disease is optic nerve compression. I mean, that's what we're worried about. We get that orbital fat, which can then cause restriction of the extraocular muscles. And I did have a patient that all of a sudden she's starting to have diplopia, and that's one of the things I said is, when's the last time your thyroid was checked? And while I couldn't see visible proptosis, I mean, you kind of run out of different diagnoses for.
But look at that picture too. I mean, you can visibly see the fat and the thickening right there.
Yeah.
I think there's little stars next to it, and look what some of those end results are. Is what we see.
You push that eye out a little bit. The exposure and the proptosis, the lid retraction, and blink dynamics and frictional forces are affected as well. And then, which is all going to lead to more inflammation and autoimmune conditions.
Doug, I'm going to challenge you here. What is it when the lid lag? Is that Dalrymple sign or something? You know how when they look up and their lid kind of sticks on there and then comes back down again?
Ooh, it's back there someplace.
Yeah, somebody pull that up, because it's probably a Vogt, because that guy has everything named after him. Yeah.
Vogt.
Vogt, whatever, John.
Yeah. It might not be OSD, and I think this is that separation.
Right.
And the one thing that's happening, though, because of the direct-to-consumer, patients are asking these questions, and I think we need to be able to respond to those patients and tell them, by do some tests, ask them, and if they're going to be seeing their primary care physician, I mean, you can run the thyroid panel on the patient, but you can also have them recommend that their primary care does that as well.
What's interesting, too, is that the very bottom of that graph was eyelid misalignment. And so we're seeing a lot more, dedicated to measuring small little, phoreas and I know there's glasses that now can break down those, and devices.
Yeah, doing the contour prism and the neural lens. And I think that's an important aspect, because with that prevalence, there still could be people that are emerging. And I think you need to look at those two peaks, those age categories, and I think you need to see the onset and what's going on with that with the patient. So patient eye exam, thyroid eye disease versus ocular surface disease.
I'm not changing anything. Are you?
Nope.
I mean, I think that, one of the things that we're so adept at is evaluating the ocular surface, doing whatever important necessary steps, but asking the right questions. I mean, you have to be a little bit of a sleuth to figure out specifically why this is happening. When you have somebody who does maybe possibly have thyroid-related disease, it's important for us to co-manage with their primary care doctors.
And, I think that's the change that I've made to my practice with the awareness, is just finding individuals that will then manage it, be willing to do the infusions, and to be able to co-manage with and send those patients out, because we're still going to take care of the dryness and the secondary effect from thyroid eye disease. And I would say that this awareness has caused me to create better relationships with some of the docs that do and get involved, because they really have to be an infusion type clinic if you're going to treat this. And we'll talk about that as well. So what therapy treatments do you recommend? And this is interesting, because I don't really think that we recommend the therapy. You find the individual that is going to treat it, because we're not going to treat it correctly in terms of the actual thyroid eye disease. So
I think the optometric trends group here, I think they stepped over their boundaries a little bit. If I could speak to them, I would probably say, slow your roll, people. Okay. Yeah. Are you really doing steroid infusions? Are you really doing orbital decompression surgery? I think not. What did Gloria say?
She said emergent treatments for thyroid disease, such as...
Yeah. Do we have that on Google? How do we pronounce that? I
think that was good.
Yeah, thank you.
Yeah, I think you hit that right on it.
Do you know that the letters at the end are indicative of a biologic? So synenogen BKBJ, they mean nothing. It's just extra letters there at the end. So if you try to make a word out of that, I think I would go with Tepeza. I mean, if I could. Can I say the name brand? I just did. Sorry, people.
You did.
Because there is only one.
Yeah,
so.
There's only one. So really, it's been a disease of waiting and watching, and really, we were treating the dry eye symptoms is what we're doing, which we're going to have to continue doing that, and that's where the co-management aspect comes in. If you have somebody, whether they're going to be prism in the glasses, lifestyle modifications, ocular lubrication, we're still going to continue to do those things. But surgical interventions, they were brutal. I mean, when you're looking at orbital decompressions and strab surgery and eyelid reconstruction.
But do you notice something? They're operating on the wrong eye. What is going on?
Well, maybe they already operated on that eye.
What
And it
is
looks
going
normal.
on? And the person got lipofusion in their lips. Did you see that? Full lips. Amazing.
So the thyroid eye disease is driven by an autoantibody activation of insulin growth factor 1 receptor IGFIR. And so what that's going to do is, in turn, that's going to create the more orbital fat. So we get this
Overexpression there?
overexpression.
Yeah.
And what we end up with then is activation, and we get more
Inflammation,
and we get the
something
orbital
that something as optometrists we should all be very, very aware of. You know, more cytokines, more inflammation. You know, regulating and changing the tissue. I mean, here the antibodies activate the signaling complex. They trigger what? More inflammation, overexpression, expansion, remodeling, fibroblast proliferation, scarring. I mean, look at the pictures behind there. I mean, Dr. Kate went out. She went nuts. Look at that stuff.
She
Yep.
once again nailed it.
Look at the beauty of that. And if anybody can pronounce that, just call in right now. We'll be waiting. Teprotumumab. Yeah. So this was approved in 2020. Yeah. What a great time to get your approval.
Yeah.
Let's get our sales staff out in those offices in March of 2020. Hello?
Let's start talking
Hello?
about that. Yeah, I think that's why everything kind of got delayed out of the date. But you can see the results of having these infusions, and this is an infusion that is given in an office on the trapezium.
Yeah.
Versus the placebo. Yeah. And we can see that reduction. I mean, versus an orbital. Have you had patients that have had orbital decompressions before?
Yes.
Yeah.
No bueno.
And that's a tough surgery for them to go through.
Nasty.
So when we take a look, and it really decreased proptosis 83%, improved diplopia 53%, reduced inflammatory signs and symptoms 59%, and improved functional vision and appearance. So.
And I also think that, the one slide that we probably didn't talk about as much as you go through these slides again is the emotional aspect it has on patients.
Oh.
I mean, and so just being able to, get the eye to kind of regress back into the orbit and reduce some of those symptoms, I think is, I don't think we talk enough about the emotional aspect of a lot of the challenges, the quality of life challenges that our patients have with ocular surface disease and eyelid health.
And it's interesting, Mark, that patient will walk in that looks like they have proptosis, and you ask them about their thyroid. And I've had like a couple of different patients go, no, I've been tested,
Yes.
I don't have it,
Yeah.
I'm getting tired of being asked that question, because there is an emotional aspect to that.
Totally, which is why I stopped asking people if they're pregnant.
What do you do?
Yeah. Oh my God. Well, we'll put you and your little one in the. No, you're not pregnant. Okay. All right.
Improved diplopia, we saw that in 53%, and you can see the numbers in the chart on here, and reduced inflammatory signs and symptoms. Again, significant improvements with the infusion and improved functional vision, and the cosmesis is so important for patients. And then again, the functional vision and what's going to happen to that patient and what is down the road for them with that if it continues to have that orbital compression. So how do you talk to them about patients and treatments?
I think it goes back to what we said before, is I alert them that there is now a treatment option, and get them into their primary care doctor, talk to them about recommending this medication, letting them know that I'm going to follow them up afterwards or before to ensure that the ocular surface and the diplopia are some of the other ancillary things that we're doing.
Yeah, and I have a neuro guy in town that is handling those for me, and so if you check around your community, and really the best would be to check with Horizon and find out who is currently using the product, so you can develop that referral and develop that communication with that particular provider.
I think it's just, we said before about, we did the survey about bringing in new products, bringing in new opportunities. don't limit your patients by not at least mentioning it to them, talking to them about it.